So while we're waiting for some more people to join in, let me just give you a quick introduction. My name is Sadaf Imtiaz. I'm one of the UKRST teaching coordinators, and I'll just be handing over to Mohammed Bessioni, who is a radiology ST5, who will be giving this webinar to us shortly. But before doing that, I would like to remind everyone about a few housekeeping rules just to make sure everything runs smoothly. So I would really appreciate if everyone keeps their microphones and their um, videos turned off so that we are able to hear the speaker clearly. And in the meantime, if you have any questions throughout the webinar, you can always pop in the chat box and type your questions there. We keep picking them up as we go. And in the end, we can go through all the questions. This webinar will be recorded and it will be put on the YouTube channel of UKRST. So just be aware of that. So I'll just wait for a couple of more minutes just to let everyone else join in. Right, so I think a lot of people have joined in and it's almost 3:06. So let me reintroduce my speaker, who is providing us with this wonderful webinar today. It's Dr. Mohammed Bessioni, who is a radiology ST5 in Merseyside. So I'll just quickly hand over to him so that he can take us through this webinar. Thank you.
Thank you, Sadaf. Hi, everyone. Good afternoon, and thank you for joining us. I'll try and keep this to the point and brief. First of all, congratulations to getting your interview. Hopefully, everyone in this meeting already have booked their interview. I've done the interview a few years ago when the scheme was new in 2022. The interview structure has slightly changed since then, but we'll talk about the new changes in a minute. We will be talking about the interview format and some preparation resources and examples, and there will be a short question and answer section in the end. This is the timeline of events. You are currently in the midpoint where the interview is. After that, your interview scores will be released together with your self-assessment scores, which will be used to give you a rank, and according to your rank and your preferences, you will be getting offers, and then you'll have the option to accept or hold the offer. And this is a screenshot from your advert of this round. So I think interviews are supposed to be 31st of March. I don't know if this is correct. Let me know if it's not. And your preferencing window should be the week after in April. And then a preferencing basically means you write your preferences. So for example, if the Northwest has 2 vacancies, you'd write down if you want the Northwest to be your first or top preference, and then you'd rank basically regions in the UK where there are vacancies. You should be getting offers mid-April, and then you'd either hold the offer or accept with upgrades, and the training usually starts in August. So the interview will be fully virtual. It used to be on Microsoft Teams, but according to the website, they are using a new software. It's called QPercom Recruitment. Hopefully, they should have sent you instructions on how to use this. The interview is made out of 2 sections or stations. Each one is 15 minutes, so 30 minutes total. There are no breaks, so once you finish a station, you just head to the next station right away. And by the way, at the beginning of the interview, they might need to check your room. So they might ask you to move your laptop or camera around the room, make sure the room is empty, and they might ask you to show an ID. So make sure you have an ID, a passport, or if you live in the UK, a driving license, for example. And the panel would consist usually from 2 consultants and a representative to ensure fairness. So moving to the interview format. So station 1, first part of station 1, you would be asked about your radiology experience, and then you would get prioritization scenarios. And then the new change this year is a review of an image. We will talk in details in a minute. Station 2 is a mix of questions between coping with pressure, managing uncertainty, teamwork, and leadership. So before moving on to the sections, I thought it is important for you to read the advert again, and these are the essential and desirable criteria, because these are the things that they will be trying to make sure that you have when they are interviewing you. They are trying to make sure you have clinical knowledge, you're able to prioritize clinical needs, make sure you maintain patient safety, and maybe undertake initial management. For example, a patient with a pneumothorax, you need to put a drain or call the A&E team urgently to put a drain. So I'm not going to go through everything, but my advice to you here is read the advert again, read the essential and desirable criteria. For example, here they might ask you about audit, quality improvement projects that you have done. What is your understanding of audit? What is your understanding of research? Is research important in radiology? What is your understanding of evidence-based medicine? So these things are mentioned in the essential and desirable criteria, and you might be asked about them. What is your teaching experience? Is teaching important in radiology? And give an example of a situation where you showed good communication skills. So have a read through these essential and desirable criteria in the ad. Make sure you understand every bit of them and ready to answer questions. Again, management and leadership skills. And some questions about your understanding in radiology. What is the radiology training in the UK made of? What do you know about the FRCR exams? Things like that. Training structure in the UK is usually made of 5 years. If you choose to be an IR trainee, you would have an extra year, so a total would be 6 years. The ST1 to ST3 are considered as general radiology training, and at the start of ST4, you would have started your subspecialty training. For example, you started doing cardiothoracic or breast or neuro. You should have finished FRCR by the end of ST1. That's why FRCR Part 1 is mandatory for your application. And FRCR2A must be finished or cleared by the end of ST3. And FRCR2B should be finished some point between ST4 and ST5. So the question about station 2, we'll come back to a station 2 in a minute. So we still haven't discussed the stations. So let's start by station 1, radiology experience. So they will ask you about your clinical experience in radiology from start till today's date. And there will be a focus on call experience, any procedures you can do, and any subspecialty training. So there are 2 styles of questions. They might ask you a direct question. Do you have experience in interventions? Or general questions. Tell us about your experience in interventions, or tell us about your experience on your own call. So you should be ready to both styles of questions. You should have a structured response. You should not be surprised by the question. And you should talk about the different modalities. that you can do. For example, you can split it into X-rays, fluoroscopy, ultrasound, CT, and MRI, and talk about each one of them. Try and split it into adults and pediatrics. You should also talk about your level of independence in each bit of them. So, for example, I can do ultrasound independently. Talk about the diagnostic and interventional aspects. Again, remember, this is an interview for someone who's starting at ST3. So ST3 means they've had 2 years of radiology training. So keep it relevant to things in the first 2 years of training, particularly things regarding on-calls or training in a trauma center. These are the things that they would like to hear. If you have done subspecialty training, make sure you mention it as well. So this is suggested the structure of the experience question. So where have you worked? For how long? What type of scans you report? If you know the numbers, I've reported 1,000 CTs, for example. You can mention it. Subspecialty, level of independence. Have you had any formal training in subspecialty? I think they might ask you this question. Have you had formal training in neuroradiology or any other subspecialty? If you had, mention it. Do you do any interventions? What is your on-call experience? And this is very, very important because when you start at ST3, you'll be expected to do on-calls independently. So they want to know that you can do on-calls independently. So make sure you stress on this experience. Also, if there is time, you might want to also mention non-clinical experience in audit research or teaching, even leadership and management. So moving on to prioritization in station 1. So you'll be giving a number of short requests to prioritize and discuss how would you manage cases and why. Multiple scenarios, you are required to prioritize and justify. You should have a system to review. So if I'm giving you information, I'm telling you I need this scan for that. It is as your day-to-day practice. You should have a system to review my request. Is this the correct scan for this indication? Has it been requested by the correct person? Is it requested by a doctor? Is it requested by a non-doctor? Is it requested by a relative? What is the age of the patient? Because the age determines if it's the correct modality. If it's a female patient in the childbearing age, do we know the pregnancy status if it's a CT? Do we know the kidney functions? Are there any other contraindications related to this modality? Is the patient lactating? Is it an MRI and there is a pacemaker or metal implants? So have a system, have a checklist, basically. And ask for more information if needed. That's what we do on our day-to-day practice. We ask for more information. Sometimes you don't have the entire information on the request. So and use your knowledge of the guidelines. So hopefully you've started already reading about some of the NHS guidelines. So you can use your knowledge of guidelines and verbalize that. So if you have a request for a head trauma, you can also always mention, I know that a head trauma guidelines is this and that. So according to that, I would do the scan or I wouldn't do the scan. So this is a quick example of multiple scenarios. It should look like something like this. You have 5 requests, and basically they're asking you which one should we do first. Medical team wants to do a CT scan of the thorax for a patient who have a mass on chest X-ray. Neuro wants to do an MRI for a patient with lower back pain. Surgical team has a 15-year-old female with right iliac fossa pain and wants a CT of the abdomen pelvis. Urology wants an ultrasound scan for a 16-year-old male with right testicular pain and suspected torsion. And ortho consultant wants an ultrasound of the pelvis for his wife who has vaginal bleeding. Does anyone want to write in the chat? What do you think? which one should be done first? Do you require any more information? Just try and do it and some interactive. Right. Okay. So, number 4, actually, torsion, according to the RCS, Royal College of Surgeons, is a clinical diagnosis, and you should not wait testicular torsion. You should not wait for ultrasound unless cases are ambiguous and you don't have enough clinical info. So again, it's one for discussion. What is the clinical suspicion in this case? If the surgeons think there is a high clinical suspicion of testicular torsion, then ultrasound should not be done and they should just proceed to surgery. So we don't have black and white answers. Sometimes the answers are gray based on discussion. Again, that's very good. So in terms of number 2, neuro wants an MRI for a patient with lower back pain. The information is not adequate. We need to know, are they suspecting Coda-Aquinas syndrome? So I would ask them, are you suspecting Coda-Aquinas syndrome? Are there any, is there like urine incontinence or loss of anal tune, for example? If they said yes, then this is probably the most urgent one that needs to be done. And the next question is, I would ask them, are there any contraindications for MRI? Does the patient have a pacemaker that's not compatible with MRI or any metal implants? So sometimes the questions will be black and white. You can just tell which one is the most urgent, but sometimes you might need to ask for more clinical info. Number 1 is not urgent at all. It is a patient is stable and there is a mass. So according to the guidelines, it should be done within 2 weeks wait. To look for cancer. So I wouldn't do this during an on-call during the night shift, for example. So I would put this at the bottom of the list. Number 2, as we said, is could be potentially urgent if they provide the correct clinical context. But again, we need to have a discussion. Number 3 could also be urgent. It could be appendicitis or ovarian torsion, but the question here, this is a 15-year-old female. So we don't routinely, yes, we would ask about pregnancy to start with. And also we don't routinely do CTs in this age. So we might do ultrasound, depending on the hospital. If this is a pediatric hospital, they would do ultrasound out of hours in this age. So again, this is something to mention in your interview. I think this looks urgent. I would check pregnancy. I would check inflammatory markers. Are they suspecting appendicitis or ovarian torsion? Usually, we start with ultrasound in this age to minimize radiation. We already addressed number 4. Number 5, this is an example of inappropriate referral. So also consultant should not be referring his wife for a gynae issue. So the correct channel for this one is they should refer it to gynae, and then gynae would do their assessment, and if they think ultrasound pelvis is needed, then they would refer it to us. And probably, again, depending on the clinical picture, it's not something urgent to be done out of hours. So as we say, it's not all black and white. Depending on the clinical context, potentially the correct order of this could be 2, 3, 4, 1, 5, or 5 is not needed at all. So we'll move on. This is a new bit, which is review of an image. This is something that they just came up with this year. So you'll be asked to review an image. They will show you an image and provide clinical assessment. So because this is new, we don't really know what to expect. But you need to prepare yourself for anything. Those of you who have done already FRCOR 2B, probably this is going to be easy for you. But these are my expectations. They could show you a single image with clear pathology, whether an X-ray or CT, or a stack of scrollable images similar to what you see in Radiopedia or the FRCR2B exam. I don't know, it could be a single image or a stack of images. If it is a stack of images, then probably you have some time to scroll and make an assessment. So take the time to scroll all the way from top to bottom and do not rush because you know you want to come up with the right diagnosis. They might provide you with a short history. Again, short history. The history could be relevant or irrelevant. Uh, in to be exams, the history sometimes is irrelevant and it is used to mislead you. Hopefully, in the interview, it's not going to be like this. And there might be some follow-up questions. So they might show you a pathology and they might ask you follow-up questions like, what do you think is the cause? What do you think is the next step? What is the management? So try and be prepared. And again, remember, this is an ST3 level interview. So they are expecting someone who has done only 2 years of radiology. It's not supposed to be complicated or sophisticated. It's gonna be something acute. Um, it's gonna be something acute, something big. Or if it's not acute, it's gonna be something like a cancer or a mass. So if you are revising some stuff, do not revise the rare and difficult stuff. Just keep it simple. Do revise the emergency on-call stuff. Um, I'm going to give you a few examples. So this is an example of a still image. Patient coming with abdominal pain. Anyone wants to write down what they think this is? So patient coming with abdominal pain and high lactate. Okay, very good. So that's correct. So this image, so intramural bowel pneumatosis, which could be suggestive of bowel ischemia. Uh, and then the follow-up question would be, what else would you look for? I would look for complications such as bowel perforation. I would look to I would look for thrombus within the SMA or IMA. What is the next step? I would also look for portal venous gas, for example. They could ask you what's the next step. I would urgently refer this to the general surgeons. So this is an example of a still image. It might be hard for a still image. It could be easier if it's a scrollable image. Hopefully the next example is easier. Okay. Anyone wants to? Yes, aortic dissection. So question is, what type of aortic dissection? Type A. Good. So yeah, that's one question. So yeah, what do you want to do? Again, referral to uh, urgent referral to cardiothoracic surgeons. Things could be simpler. They could just show you a chest X-ray or something, but I just wanted to show you some CTs and one MR maybe. So this is the patient coming with head trauma. Yeah. So there are actually 3 findings on this. So there is okay, 4 findings then. So there's subdural bleed, midline shift, subgaleal hematoma. Yes, and there is also some subarachnoid hemorrhage. Um, so what would you do next? So I would scroll throughout the entire scan, make sure I'm not missing anything, any tonsillar herniation or anything like that. And also I would put I'm giving you an answer to the question. What would you do next? I would also put the bone window to make sure there are no skull fractures. That's what you do in your practice. Make sure you mention things like that. And the patient needs urgent referral to neurosurgeons. So yeah, good answers. This is the last one. It's very unlikely for them to show you an MRI. I think this is probably the only MRI that they could show you. the only acute MRI that they could show you, patient coming with back pain. Yeah, spinal compression, and there is a fracture of L2, which is causing spinal compression, and the patient needs urgent referral to the neurosurgeons. So yeah, these are few quick examples. They could just simply show you an X-ray with something like pneumothorax or massive effusion, or X-ray of the abdomen with pneumoperitoneum, and the questions are going to be the same. What's the next step? I'm going to do a CT. I'm going to speak to the surgeons. If it's a pneumothorax, then if it's traumatic, I'm going to speak to the emergency team to put in a chest drains, something like that. So again, keep it simple. It's going to be all acute pathologies or a big cancer, for example, a big lung cancer or a big hepatocellular carcinoma, something like that. But it's not gonna be like the FRCR2B, the rare and unusual cases. So moving on to station 2. So station 2 is made up of 3 types of questions: coping with pressure, teamwork, and leadership. They do not need you to ask you one question in each of these categories. They might ask you a couple of questions in teamwork, and that's it. A couple of questions in leadership, and that's it. But these are basically ideally they would ask you one question in each category. So try and read about these type of questions and how would you answer them. I'm gonna give you an idea, and hopefully with the resources that we will provide, you'd be able to and prepare more. It is important to have a structure in mind to answer these questions. Again, you don't want to appear as surprised, regardless of the type of question. If you have a structure, you should be able to answer. The more you practice, the more you will answer naturally. In the book, I'm gonna send you, there are few structures that they suggest. One of them is STAR. This is for situational questions. What is a situational question? For example, give us a situation when you were under work pressure and or there were like work crisis or something and you handled it well. So there is a structure called situation where you where you say what's the situation, what's the task, what action did you do, what was the result or reflection. In terms of ethical questions, for example, there's someone telling you about a situation where a consultant was drunk. So they're suggesting to use the SPIES information. Seek further info, make sure patient safety is not compromised, take the initiative to fix the situation, escalate to the higher channels or seniors if needed, and offer support to your colleague. So these structures are discussed in details in the book. Yeah, so situational questions. When you're using the STAR, you'd explain what the problem was. You explain to the interview panel. So the problem was, for example, I was doing a busy on-call and PACS was not working. And there were like 10 CTs that I couldn't report because PACS is not working. So as a result, I was trying to give the clinicians, so that's the task, I was trying to give the clinicians a verbal report because PACS is not working. That's what I was trying to do. What action did you do? I went to the CT scanner and I reviewed the images on the CT scanner itself because PACS was not working, and I wrote down some notes in a piece of paper. And the results is I managed to safely convey the results of the urgent scans to the clinicians. I learned that there should be a backup system for these kind of situations or extra training whenever there is an emergency with PACS. That's a very small example of a situational question. Yeah, so they could ask you, can you give us an example where you dealt with a difficult colleague, where you dealt with a difficult or angry patient, or where you had to prioritize your work? So the key here is to know the structure and have some examples in mind for each of these situations. And your main concern always should be patient safety. So when you are addressing any situation or ethical problem, make sure patient safety is number one. Handling stress. This slide is was prepared by my colleague Dalia, yes, last year when we delivered this talk together. Basically, the interviewers need to know that you can remain calm under pressure. You are able to deal with stress. So when they ask you about stressful situations, remain calm, take a step back, try to put things in perspective, identify the cause of the stress. What can you do to deal with stress? Take a break. So if they ask you what can you do to deal with stress, seek advice from colleagues, prioritize your work, identify resources available, and share workload with others. Planning your work could also decrease stress. Learn from previous stressful situations, discuss with senior colleagues, identify any training needs. So these are examples of answers. How do you deal with stress, basically? You can also say that I de-stress by preparing myself for stressful situations, such as relaxation, hobbies, sports, social life, holidays. So that's a general scheme on how to answer questions about stress. A few examples of teamwork questions. What is a good team? What is a good team player? What is a good team leader? Difference between team leader and team managers. Again, most of these questions are on the internet on few resources. Examples of situational questions. Give an example of a situation when you participated in teamwork.
Sorry, Mohammed, we cannot hear you, and your screen has stopped sharing.
Can you hear me now?
Yes, it's
Yeah.
fine now.
Which part did you miss? Did you miss the whole thing or?
Oh, no, it just stopped right
That's
now.
okay.
So it's fine. But your
I'll,
screen is
yeah, I'll
not
share it
sharing now.
again. I think
Okay,
my
thank you.
mic was disconnected. Okay. Hopefully you can see the screen now.
Yes, it's all good now. Thank you.
Thank you. So yeah, describe a situation when you showed a professional integrity as a doctor, or you showed leadership. Describe a situation when you showed good time management, or where you're working under pressure. How do you deal with a patient who's skeptical or does not want to have the scan or intervention? Uh, so examples of ethical questions. Drunk colleague is a classic. A mistake in report, a difficult patient, and also examples of clinical governance and academic questions. Questions about audit. What is your understanding of audit? What is the audit cycle? What is an example of audit you've done? What is clinical governance and what is research? In terms of the study material, so there are plenty of guidelines on RCR and NICE website. For example, head injury in adults and peds, cervical injury, CTPA versus VQ scans in pregnancy, suspected CUDA equina, and non-accidental injury. These are just examples. There are many other guidelines. So the more you can read, the better. There's also, because I'm doing cardiothoracic, there is also a document from RCR and RChem about guidelines in chest pain and aortic dissection. If you are a member of the RCR, there's a tool that's sometimes useful. It's called iRefer. It should be on the RCR website. You can put down the pathology, for example, appendicitis. It will list down what is the first line of investigation and what is the gold standard and when would you do that investigation. I think it's also very helpful. The book that I was quoting is the medical interviews book. I will show you in a minute. The medical interview book does not have any medical questions. It just have all the ethical situation and management and leadership questions. Also, there are some question banks on radiologycafe.com. And that's the medical interviews book. I think it was very useful for all the non-medical questions. So to summarize, just know your CV inside and out, summarize your strongest points and reporting numbers, have a structured answer to answer ethical scenarios, make sure that the patient safety is always your top priority, have some answers ready for situational scenarios. On the prioritization scenario, remember your day-to-day practice, remember to always ask the important questions and have a checklist ready. Dig deep into every question as you do in your usual vetting. And the interviewers want to hear some words related to the NHS practice, such as I would refer this case to the MDT. If the patient want to complain, I would refer them to the PALS. PALS is called Patient Advisory Liaison Support. PACS, Radiology Information System. Familiarize yourself with these and use it when possible. Yeah, good luck. Let me know if you guys have any questions.
Thank you, Mohammed. That was really insightful. I think there were a few questions, but Dr. Abir Khan has been answering them as we went on. I can't see anything that's unanswered at the moment. Oh, there's one now.
Yeah.
Could you recommend emergency radiology book?
So the one book I was using, I don't know if there is any better ones. It was called On Call Radiology. I think that book had some of the acute cases plus protocols and findings. There is also, I think, emergency radiology course on Radiopedia if you are a Radiopedia member. I'm sure there are plenty of other resources, but these are the two ones I know at the moment. In terms of the time, you will not be given more than 30 minutes, basically. So they are strict in that regards. And also, I think every station is kept at 15 minutes. So try and give as much information as possible, but again, keep it brief. So when you talk about your CV, you can talk about your CV for 30 minutes, basically, but try and summarize the main points quickly. And then if there is time to talk about more points, then you should be able to do that. Right. So the question about shortlist reserve, I don't have any experience with that, to be honest. In my time, there was no shortlist reserve. I think it depends on whether someone would decline the offer or decline the interview, I think. And the chances of this happening is not high. Right, so there's a question about interview mocks. Can I ask you guys when is your interview exactly? Is it 31st or anyone having interview before the 31st? And the bureau has kindly given some insights about ST3. We're expected to be reporting plain films, ultrasound independently, and on-call start from ST2 shadowing and independent at ST3. So yeah, remember that in your interview. That's the level they want you to be at. One question overtakes the other. Do they lead you into stop talking about the part? Yes, if you talk too much, they might just stop you and say, "Okay, thank you," which is fine. Don't think they are being rude or anything. They need to keep the time. So if they interrupt you, it's okay. If they don't look at you in the camera, because sometimes they need to look down to write some notes, again, this is okay. So yeah. So yeah, as Abira saying, we will see if we have capacity, because we need enough trainees to be able to conduct mocks, but it can't be promised at the moment. So we will see and let you know, guys, if we can do mocks. I think to start with, we need an idea about how many of you are having interviews. How many people are in the session at the moment? So I don't know if everyone in the session is having an interview, because it's around 30 people. Probably unlikely that all 30 of you would have interviews, because at the moment they've advertised maybe 15 posts or less. But maybe we can do a poll on the group and see how many have interviews, and we see how many trainees are available to do mock interviews, and based on that we would decide if we can do that. Apart from this point, are there any other questions that you guys have?
Right, I can't see any more questions coming in. We'll give it a couple more minutes. If somebody wants to ask anything, please pop in the chat box now. Thank you so much, Mohammed, for this webinar. There is a question now: what to do in case of mistake in report?
Right. So we will follow the structure. Basically, ethical scenario structure is PIES, seek more information. What was the mistake? What kind of report? X-ray, CT, MRI, how significant is the mistake? Make sure you ensure patient safety. Is it a big mistake? Did we miss an acute finding? So we need to recall the patient. We need to do emergency management and let the clinicians know. Or did we just miss a lung nodule? In that case, we might just need to do a follow-up X-ray or a follow-up CT. So you just follow the structure. And the initiative here is you do all the work. You let a senior member of your team know, or a consultant, recall the patient, follow the duty of candor. If you missed a finding, or the patient was suspected to harm, you need to let the patient know. And if you need to escalate this, if it is something big that you've missed, maybe you'd involve a senior member of the team. And finally, the reflection. The reflection is to learn from your mistake. We all do make mistakes. How do you learn from mistake? For example, if you've missed bleeding at the base of the skull, you can say, I will add this to my review my review areas. So in the future, I will always make sure I check the base of the skull for bleeding. This is a quick way to answer the question. But as I said, I think in the book and the online resources, there are many questions and many model answers.
Can't see any more questions. Just a quick heads up and a quick reminder about the feedback form. So it is an anonymous and a very quick feedback form. So if you all can just fill in, that will be really great for us and our speaker as well. Yeah, I don't see any more questions. So I think we'll call it a day. But this was really amazing. Thank you so much, Mohammed. And like you mentioned already, if in case we do come up with the capacity and the planning of any mock sessions, we will let you all know. But we will have to decide about that, and we can always let you know if anything comes up. But thank you everyone for your time, for joining in. And if you have any more questions, any more concerns, you can always email us at the UKRST email. But I think that's it for today. And thank you so much for joining. Good luck for your
Thank you.
interviews, everyone.
Good luck, everyone.